This is EHJ Today at the annual scientific sessions of the American Heart Association in Chicago 2014. And I'm talking to Dr. Brawnwald from the Brigham and Women's Hospital and Harvard Medical School, who needs no introduction. Welcome.
Thank you.
So we wanted to discuss a little bit the TIMI program, which was an extremely successful program, clinically very relevant. And let's start maybe first with the question, how did you start it? Because initially you were very interested in hemodynamics, worked in the dog lab, and then you changed direction.
Well, you know, this comes at a good time because today, this evening, we're celebrating the 30th anniversary of TIMI. So
great, congratulations.
Yes, thank you. But TIMI, at least in my mind, began much earlier, and you're correct, Tom, in that I started out in physiology. And one of the first projects that I worked on in physiology was the determinants of the oxygen consumption of the heart.
Exactly.
And I worked on that in Stanley Sarnoff's laboratory, and then when I got my own lab, continued to work on it. So I worked on that for actually for 13 years. And that was mainly in the dog.
Yes.
And we came up, and I think it's with three determinants that were important. One was tension development. The second was contractility or rate of tension development.
Right.
And the third,
DPDT.
Yeah, DPDT. And the third one was simply heart rate, so the number of contractures. And that, to boil down 13 years of work in 2 sentences, was responsible for 92% of the oxygen consumption of the heart. And there are many other factors, but they were relatively small. Yeah. So, that was, in one sense, one side of the equation between supply and demand.
Right.
Now, when we started this work in Sarnoff's laboratory, and when I moved it to my lab, we weren't really thinking very much about clinical. But in the so this began in '55. So as the '60s developed, it became clear that myocardial infarction was a mega problem, and that it was a problem in supply and demand.
Exactly.
And then I became very interested in can you modify infarct size. About the time also that I left the NIH and moved to University of California in San Diego, and we hypothesized that by altering the balance between supply and demand, one could modify infarct size. And demand would be modified by beta blockade, for example, by hypothermia.
Yes.
And supply would be modified by the degree of coronary constriction. Exactly. Now, those things sound so obvious now, but they weren't obvious at the time.
Yeah, sure.
And so this was put together really in a paper that was first authored by Peter Marocco, who was a postdoctoral fellow with us.
Yeah, he did most of these studies, didn't he?
And that was published in Circulation in 1971. When I moved again to the East Coast in the '70s, Chazov,
yes, from Moscow.
From Moscow, did something that was quite daring. We hypothesized in the '71 paper that if one could improve reperfusion, then or diminish demand, that inpatients rapidly brought to the hospital. And it turned out that, of course, with intracoronary streptokinase.
That's what he did.
That's what he did, and he showed that he could open an occluded vessel, and that was very important. The next thing that we did, which just sort of antedated TIMI, was to show that with intracoronary streptokinase, there was actually salvage of tissue. And we used intracoronary thallium.
Yes.
And if, of course, you have to have live tissue to concentrate the thallium.
Otherwise the pump wouldn't work.
Exactly. And we found that it did.
Yes.
So that then pushed us to to think more and more about thrombolysis.
Right.
And we had a number of conferences with the NHLBI, and finally they asked me to lead a group. And that was thrombolysis in myocardial infarction. That's where the name TIMI comes from.
Exactly.
And we had a meeting at the American Heart Association 30 years ago. Mm-hmm. And that's why I'm saying that this is when this was born. So, so that was in 1984.
And what was the first trial then?
The first trial was, and we didn't call it TIMI 1 because we didn't know there would be any others. Like the First World War was not named the First World War. It was named as the Great War, right, exactly, until World War II, which made it World War I. So anyway, the first trial was intravenous streptokinase versus intravenous TPA, and the endpoint was reperfusion. And that's when we came up with the concept of TIMI 1 flow, TIMI 2 flow. How do you grade reperfusion was pretty obvious. So that was the first trial, which was stopped by the Data Safety Monitoring Committee because the difference was so large, that TPA was so superior to streptokinase. And then remaining with NIH support, we went on to TIMI 2, which looked at PCI and that combination. At that time, PCI was just balloon valvuloplasty that was originated in your university, and we found that there was a trend toward benefit, but I don't think we were adequately sized. Although we thought 3,000 patients at that time, back in 1986, would be enough. Yeah, so it was there, but it was underpowered. Right. Then we went on. TIMI 3 was, we assumed at that time that non-ST elevation MI and unstable angina were mild cases of STEMI, and that intravenous TPA would be useful there. Turned out it wasn't. So that was a very important negative. We were quite surprised because we thought that, the vulnerable plaque, the thrombus of the plaque, so that we would be reperfusing subtotal obstruction. But, and then ISIS came out, and all of the other trials also showed that that non-ST elevation MI is not helped with lytic therapy. And so we continued over the years to work with anticoagulants, antiplatelet drugs. Thrombolysis is less and less of an issue.
Statins and also. And
statins, yeah, and then so in a sense, maybe the TIMI name is wrong.
Historical.
Historical, but we stuck with it. It's like Coca-Cola. And we have also been extremely interested in biomarkers. We have a core laboratory that's headed by Dave Morrow. We're now getting into a major way into genetics in cardiovascular disease, and Mark Sabatine and Jessica Mega are heading up that program, and we have some so these are really, when we do a clinical trial, we want to answer the key question, but we also want to gather data and gather specimens. So we have a biobank of several 100,000 specimens now, and we have a genetics bank that's almost as large, and I think that is one of the things that we're spending more and more time on.
And how many trials did you do so far?
Today Chris Cannon reported on the Improver trial, which we can talk about, which was TIMI 40, but and the reason it has at the number 40 is because it took us 9 years. This was the longest trial that we've ever done. We're actually doing with an anti-immune compound, an immunosuppressant is going on in TIMI 60.
TIMI 60.
Yeah. TIMI 50 was Vorapaxar, the TRA receptor antagonist, which is now has been approved by the FDA and I think by the European agencies. It's going to be approved. It's a very potent antiplatelet drug. It works at a different site than the others.
Right. So overall, every half year a trial, sort of.
Yeah.
60 trials in 30 years.
Yes,
that's remarkable.
Yeah, that's right. Yeah.
And so, what's the future?
Well, I think the future. You know, as the future in cardiovascular science is. I think is to understand what we're doing, precision medicine, precision science, precision cardiovascular science. I think the concept of treating everybody exactly the same way is maybe
too simple, huh?
Yeah, it's too simple because I think people are different. I think as time goes on, I think we're going to have anti-lipid therapies, which are dependent on the reason for the LDL elevation, and also the biomarker thing. I mean, one of the interesting things, one of the first lessons that I learned in the biomarker field was in a trial back around TIMI 21, which was the tactics trial. And that was a trial about conservative versus aggressive management of non-ST elevation, MI. And on the whole, it showed that aggressive was superior to conservative, but not by a lot. It was like maybe 25%. We expected more. But that was the time that the troponins became available. And when we looked at the troponins, and of course they were crude at that point before you got to the high sensitivity. But the analysis of the troponin showed us half the patients had an elevated troponin and they had a 50% benefit.
Exactly, yeah.
And the other half had no detectable troponin and they got nothing.
Right.
So I think at that point, all of us became very energized about getting more information and saying, okay, everybody with this diagnosis gets that treatment. So I think we're going to have to be more precise.
Yes. Thank you very much for that. And again, congratulations on the 30th birthday. Thank you.